Welcome to Coping with COVID-19, an editorially independent program from the editors of Modern Aesthetics Magazine and Practical Dermatology Magazine. In this episode, Drs. Joel Cohen, Doris Day, Steve Diane, Michael Gold, Mark Nestor, Joel Schlesinger, and Amy Taub talk about making plans to reopen medical and aesthetic dermatology practices.
Three things going on. Number one, we have to understand the science better for who's getting sick, why, number one. Number two, one of the big pieces of science that's been sensationalized that we don't know is what are the simple things we can do to mitigate getting sick. So for instance, nobody's done a real good study. If two people wear masks and one is infected, what is really the transmission rate? My understanding is it's very low. Okay, so if you're mitigating, for instance, I have no problem going to a store with an N95 mask and gloves on because in Florida, everybody's wearing masks anyway. I'm not going to get sick. I know I'm not going to get sick. Between that and social distancing, I'm not going to get sick doing that. You and I and all of us here know that we can do things and go out in a safe way. There's no reason why I can't go to Whole Foods the same as I can go to a sports store if everybody does the same type of mask, social distancing, etc. What we need to understand is there's going to be ways of moving forward before we have a vaccine that are safe, and they're going to keep the numbers of infection down to a level that we can deal with. At the same time, I think what's happening is day by day, we have newer and newer pieces of information to keep people healthier. Okay, we know that hydroxychloroquine doesn't work. Okay, that's a big piece of information because people were getting it. It's interesting. I'm waiting to see about ivermectin. Okay, and there's two studies that are being done on exosomes now that have some promise. And there's some issues, some data out of Israel using stem cells with very, very good results. So we're getting more and more information day by day that as we understand, I mean, a simple thing that they realize that people, when they're on their stomach, survive much more if they're in the ICU than they're on their backs. So, you know, the risk factors of people dying as we move forward week by week and day by day goes down because we learn more about it. Okay.
Can we just spray our lungs with Lysol?
I got news for you. You think that you want to hear something funny? Okay. We certainly can do it with hypochlorous acid.
Absolutely.
So, you know, that wasn't so stupid, really. Stupid about Lysol. Hypochlorous acid, you know, why can't you do an aerosolized, and would that work? It'd be very...
The head of Tide came out today and said, please do not take our little Tide cleansing pods and stick it in down your throat. It's not going to work.
Mark, you said that you feel you're not going to get infected because you're very careful about wearing a mask. So,
wait.
Let me just finish.
And everybody around us in Florida.
So I heard you.
Has to have masks on.
So I wear a mask every day at work. I consider myself a very experienced mask wearer. However, I don't typically wear anything like the KN95 mask that I wore yesterday to do Mo's. I haven't been to the office again in 6 weeks. That mask fits like a beak. It's very uncomfortable. It doesn't fit on my nose very well. And I am not used to wearing it. So I found myself, when I finished surgery or before surgery, I found myself actually pulling it down to talk to somebody before I realized stupidly that was by rote, and then I had to actually put it back up. So we have things that we do that we don't even realize because we're used to wearing masks. Other people may feel different, but I ended up touching this area a few times, just making it more convenient for me, number one. Number two, consent forms are still on the iPad as much as we clean it and everything else, and you have patients use cleaner before they touch it and you touch it and everything else. There's a lot of things that we touch without gloves on that they touch without gloves on because otherwise it just wouldn't work. So I beg to differ. The amount of times you touch your glasses, I had surgical glasses on yesterday. They're these big Oakleys, and then I had to put my loupes on when I was repairing an eyelid, and those shields don't fit over it. You can't say you won't get infected. And I don't know whose Instagram this was, but I saw something last night that it showed a picture of, you know, like a Zoom conference, and you look at it, but it was all the people who had died that were ER doctors in the past month.
Okay, so, Joel, a couple of things, okay? and I'm not disagreeing with you. I think the simplest thing for you is have a rhinoplasty so your mask fits better. It'll work much better.
And we know somebody in the corner here that can do that.
So here's the issue. Number one,
If you could get there.
Our habits are different. What I was saying is in Florida, the law is if you go into Whole Foods or any place, everybody going in there has to wear a mask. The data shows if 2 people are wearing a mask, it is very, very difficult to transmit. That's what I was saying. But I agree with you. Our habits aren't keen to being really good about touching ourselves, etc. And we have to change our habits. I absolutely agree. Now, certain things I will tell you we can do, and I talked about this with David Goldberg, etc. We are not doing any signed written consents on the iPads. We're doing verbal consents, reading it to the patient, saying, here's the consent, and you're verbally approving it, and that's it. We're having them touch as little things, and it's because of COVID, and we have that in there, okay? And we actually are doing, we started doing telemedicine with consents, sending it to them to sign it. We stopped doing that. We're doing it all verbally, and we're putting a little macro in saying the patient consented to X, Y, and Z. Legally, verbal consents are fine, okay? Especially under COVID when you don't want to touch anything, have it be fine. That's number one. Number two, yes, I agree. We have to change our habits. Touching ourselves, touching our masks. Now, I will tell you what I do is I have LaserSyn and EpiSyn in every room spraying the mask. And I'll tell you, I come home and I have a little mask that I go out with. I spray it with EpiSyn or spray it with LaserSyn. I feel really good because it's not going to hurt me. It doesn't seem to hurt the mask. Okay. I'll spray my glasses with it, etc. We have the ability non-toxic.
Stop spraying your noses with it. You can spray it into the nose.
You can spray the inside.
And then you get in your mouth and in your eyes. It's no big deal.
Right. So
concentration is that?
This is exactly what we need to do moving forward to establish new ways of doing things to protect ourselves. Number one. Number two, protect our staff and for our patients both to be infected and to infect us.
Can I say something?
Go ahead.
Can I say something? So I decided to get this antibody test, that's the pinprick one it's called BioSense, and it's being sold by Shine and Medline. It's an IgM, IgG, and it takes 15 minutes. And yes, there's a zillion things that it doesn't tell us, but it could tell us if somebody has IgM, for sure, we're not going to send them home, right? I'm talking about employees. And if somebody has IgG, we'll be like, okay, either you had it or you had another coronavirus. But at least if you don't have the IgM and you have the IgG, based on prior viruses, even though that's a very imperfect science, we can assume that maybe you have short-term immunity. We don't know. That doesn't mean that person would not go without a mask or do anything else. All that means is that we wouldn't send them home, and we just have a slight modicum of more information than we had, because it's so frustrating to have no information.
I agree.
I agree.
There's been some discussion on some other text change that what you proposed right now could have some inherent risks for employers. So first of all, if you have somebody who tests antibody negative and then they work at your office for 2 days or a week, and then they test antibody positive, then there could be some inherent liability of the practice.
Agreed.
Contributing possibly to their conversion. So that has been a question for employment attorneys, and many would say that there's risk from that. So I think we should discuss something like that. Secondly, Mark, I'm not sure I'm comfortable with people just having a verbal consent. You could have verbal consent to brain surgery. So I'd still prefer a written consent, and we have our standards of doing things. And the third thing is, there is the opportunity that some people actually have said, maybe there should be a consent form when you walk in the office, that the uncertainty of COVID, we're taking safe practices, but we have no idea. But then again, there's no consent form when you go to the grocery store. Are we opening it up to, saying that they might have gotten something at our office when people forget about the fact that they've been to other places as well? So those are three things to chat about.
And in New York, they have to get to the office, so they're often in public transportation. I mean, in a place like New York, even
I
for myself,
definitely I think we should have a consent form, because just for what you said, let's say you're going along and then all of a sudden one of your doctors or your MAs gets COVID. And then all of a sudden you have this little hive of people that have gotten COVID from your office. And then that patient could say, well, I was there and I saw that medical assistant and I know I got COVID from your office. I think it's a good idea, even though they could get it from anywhere.
No way.
I'm listening.
We actually have a consent that Michael and I and David Goldberg discussed this because I sent them the consent. Dan Siegel and I came up with a consent. And the reason for the consent was two things. Number one, to make sure that patients who are coming in understand that they're coming in under a risky situation. They're also coming in with the knowledge that they may not have to come in. We may be able to see them under telemedicine, okay? And then we have, whether it's legal or not, something in there saying that they're abstaining us for liability for getting COVID because they want to come in.
And we're going to use it too. I mean, the situation that I'm living in Tennessee is listening to all you. Sorry, I came in late. Our stay-at-home ends next Friday. Nashville is sort of blocked from the rest of the state. So Nashville, Knoxville, Memphis, Chattanooga, we're not part of the state mandates. We have our own city things that are taking precedent over the state. And the mayor came out yesterday and basically said that starting May 1st, we are allowed to go back to, it says elective surgeries may commence if you're on a patient who's under 70 and in good health. The governor has said no health care, okay, in anything. But the Nashville mayor who has authority over it, says on May 1st, we're allowed to start again with elective surgeries for specific things. And the documentation, like you've been saying, we have to document everything. The minute the patient walks into the office, temperature checks. We have to have the consent form that Mark was talking about in some form or fashion for not only the patient, but all the employees have to be checked and screened every day. And there's guidelines that our mayor has set out for all of that. And then phase one of our reopening is we're Nashville, it's bars and restaurants, okay? No doctor's offices are mentioned in any of that. But phase two, it says elective procedures can happen on anybody. So, but that's a phase two. But on the preparing to open part of this, elective procedures may commence. So it really doesn't say we can do it, and it doesn't say we can't do it. And so we're actually going to go back to the mayor's office to get a definitive answer, because our curve is going up.
Truly, right. what this comes down to, I think, is safety for both yourself, your patients, and your staff. And I think that you want to be as safe as you can and open wisely. And where you can use telemedicine to decrease the risk either to yourself or to your staff, you should absolutely do that. The other thing that I have had some concerns, at least in my practice, is with pregnant staff members and potentially patients. So we have a pregnant staff member or two who are very early, and we have taken the approach that we don't want them anywhere near risk factors, and that's going to be something that we have to really resolve with ourselves. It's going to come down to how we feel if one of our staff members becomes sick or, God forbid, dies from COVID, and what our liability or
Joel, I had a pregnant patient call me up a couple weeks ago who happened just to go out in the yard and basically had probably one of the worst cases of poison ivy I've ever seen. And she called her OB and said, you know, who do you have a dermatologist? And they said me, and she said, see if he's open, because she'd rather her come to me than go to her. And so, yeah, and it was we had that same discussion. I mean, do we want to see somebody who's pregnant? You know, how do we deal with it in an office and so forth? So it's a major issue.
The question really is, where is the exposure greatest? So if we're taking precautions in our office, versus that pregnant person or somebody in their household going to the grocery store.
The
They're
bowling
probably
alley.
a lot safer in our office no matter what than they are in a grocery store.
Well, you know,
Okay.
they're safer with less exposure overall. So they may have to go to a grocery store. They may have to do other things. They don't necessarily have to come in. I have one person who is 6 months pregnant, and I'm thinking very strongly that I will figure out for her to stay home and not come into work, and figure out how we can, you know, we're downloading we're downgrading the practice in terms of volume anyway. So I personally would not feel good about her coming into the office and risking any exposure. She has one child at home. She's 6 months pregnant, and it would kill me if anything happened to her that I thought I could prevent.
And it's
Can we talk about
a poison ivy patient you can see via telemedicine. If we can't diagnose poison ivy via telemedicine, we can't diagnose it.
Well, so this was the thing where she
Right, Steve?
You're right. So yes, the answer was yes, but it was so bad that the OB actually thought it wasn't poison ivy, and it was before I even was doing telemedicine.
And it was pup.
Yeah, and it wasn't pup. All right. Yeah. So there were a couple other. Can we change subjects for a minute, because I wanted to bring something up. I may have missed this part of it, but we had actually all gotten some emails earlier in the week about. When we do reopen, what is it going to look like from all of our points of view? And I promised that we would ask it on this call today. So let's talk about sales reps for 2 minutes or so. How are you going to do this in the new environment? I see lots of head shaking.
Virtual.
We don't need them. Honestly, they don't need to be there. We don't need our staff exposed to people who go into all different kinds of offices, our colleagues, and different types of medical professionals.
that was actually the first thing I got rid of was my sales reps. Was like, nope, we're not having any more lunches.
This may be the best thing that ever happened from COVID.
All right, so
You know what?
So take it from the company point of view. So let's separate it into two parts. MedDerm, okay? MedDerm, you can definitely do virtual lunches if they want a company person wants to pipe something into your office for 15 or 20 minutes or whatever. But Doris, you're going to see reps. You have a small office. You said in your email.
No,
Okay,
I'm not going to see reps, and I do like my reps. I think that reps provide an important service for my med side. They bring samples, and I think those relationships are important and helpful. I feel badly because I don't want them to lose their jobs either. So it's tricky right now, but it's just not safe. I have 1,500 square feet. I'm gonna downsize on my MAs. If you are graduating, going to medical school or PA school, and I'm not going to rehire right now. So I'm going to just be down to as few people in the office. I want every patient who comes in to feel like the office is otherwise empty.
Right.
So anybody who doesn't absolutely have to be there should not be there.
And you're all in agreement with that?
Absolutely.
On the MedDerm side? How about on the cosmetic side? Let's do on the filler toxin side. Do they need to come?
No, same thing, virtual.
All right. How about on the device side? You want to buy a new device in 6 months or a year? Are you going to let them come in?
No.
No.
How are you going to get a demo?
Well, that's we're not going to get a demo for a while. I mean, it's an interesting.
I said 6 months to a year. Whenever people do, again,
We'll see.
You'll see. Steve,
But by that time, we'll have a vaccine in a year or so. Let's
Steve,
hope.
what do you think?
No, I'm not bringing anyone in. I don't see myself buying a device in the next 6 months to a year.
There you go.
I mean, I think we've all been on these calls enough that the marketers out there have been saying, things are going to be back in 3 months or 2 months or whatever. And Steve, I will plug Steve for a moment. Steve has been the word of, well, people, I don't think you're really on the right track. And it's been refreshing because, again, I think we're living in a world that, if I had $100,000, I could buy, instead of one laser, I could buy 10. And I'm, that may be an option.
So this is what I've told the laser companies that have talked to me. Shift to rent to buy. There's no way anybody's going to buy a device right now. Maybe they've had an eye on your device forever and they can't afford it, but when things start to pick up, they'll be like, you know what, I'll try it for 3 months. If it seems to do well, I'll keep it. And if not, I can give it back. They're never going to make it any other way, in my opinion.
And look what's happening with cars. I had this conversation before with a few people. I mean, if you look at what's happening in the automobile industry, they're like down really tremendously, okay? And what they're doing is they're realizing that, number one, people are getting 6 months without having to pay their car payments. They're saying you can return your car.
Right.
You know, if you lose your job, we're going to pay for it.
And somebody made a comment to me that you got to read the fine print in those really carefully because they may not all be what they think that what we're hearing.
Of course, I agree. But what I'm saying is it's the same issue here. You know, when we open up, device companies are not going to be selling anything for a while. And I think that, you know, a lot of people in the device industry, as you know, realize the writing's on the wall. And if you have gone belly up or they sold very cheap, you know, those device companies that have fillers and toxins and lower price, as long as they're going to meet their customers' needs and, you know, and really trade out things that are close to expiration or expired and not leave it up to the customer or the physician to eat that, they'll do well because, you know, again, it's going to be a lower price point. But the bigger price point items, I agree with Amy, you know, unless you're going to do something very unique, nobody's going to pick up a
You're not going to let the reps come in your office. You're going to have you'll let them deliver the device and you'll set it up, or they'll just send it so it's set up, and then you'll virtually train.
So let me ask you this then. Do you think the patient expectation is going to be that when they come in for the neuromodulator filler or laser, that they're going to do the same thing with us? Or is it going to be that they're expecting that our prices are going to be lower, and they're going to ask for exceptions that way?
Great question. And I think the bottom line is that the market's going to tell. The market is always told. I mean, our prices are always in this group are always much higher than the market anyway. And I think that people will pay what they'll pay if they want the best, and that'll always happen. But I think overall in the marketplace, the prices are going to go down.
Well, there's going to be a lot fewer people that are going to want to get this because.
You think so?
Yes.
Yes.
I think after the first glut of the pent up demand patient, which will be the first week or two, the group that's saved money to come in for a toxin or a filler or a laser procedure, either some of them may not be working right now, and then they don't know if they're going to go back, and you know, choice between food and a toxin. You know, in New
How
York,
long do you think that's going to last?
But in Nashville, they're going to choose food. It's going to last for a while.